Thank you, Dr. Vaidya. So, last but not least, we come to our oncologist, and this is Dr. Thor Halfdanarson. He lives in Minnesota, right? But that's not where he's from, but I'm going to tell him not to tell you where he's from and see if you can guess by his accent. Please give a good hand to Dr. Halfdanarson.
Well, thanks for the introduction and thanks for the invitation. So, looks like I have my slides up and you can all hear me okay. And I think this is my remote. So what I wanted to talk to you about is the systemic therapy of neuroendocrine tumors. And when I say systemic therapy, that means essentially drug therapy, although I will talk about PRRT. So these are my disclosures. So research support, I'm on a couple of guidelines panels that both NCCN and NANETS. These are my objectives. So I wanted to talk to you a little bit about how common NETs are, and this has been covered, so I will probably go through this fairly quickly. And why do we need medical therapies? Why do we really need medical oncologists? And what are the current options for drug therapy? Where does PRT fit in? And then if we have time, we'll talk about genetic testing, some immunotherapy, and other things that are on the horizon. So a little bit about epidemiology. This has actually been covered by previous speakers, so I won't dwell on this. But what I did do is that I tried to calculate based on the incidences in the US, and incidence meaning the number of new cases diagnosed over a period of time. So we talk about annual incidence is really the number of new cases diagnosed over a year. And if the people of the state of Washington have the same incidence as the rest of the country, it should be about 500 new cases in the state of Washington per year. And they are mostly in the GI tract, which I'm going to show you here in a little bit. So we're seeing an increase in the number of new cases, and I think it's real. I think some of it is that we're just getting better at detecting tumors that would have gone undetected for a longer time, and I'll show you some data for that. But I think this is really real, and we don't know why this is happening. We don't know why people are getting more neuroendocrine tumors, and this is something in the environment. We haven't really changed genetically over the last 20 years, really not. And so we'll talk a little bit about that. So most of the neuroendocrine tumors are in the GI tract, so in your abdominal organs. And this is how it breaks down. And so mostly small bowel. Rectum is very common, but rectum is not common in my practice because those are usually little polyps. The gastroenterologist goes in there, he removes it, and then he scopes every so often, and it just never comes back, or rarely comes back. Pancreas is fairly common. Colon is a little bit of a different entity out there. So colonic neuroendocrine tumors, they can be fairly nasty. They can be high grade and can be hard to treat. And then we have the stomach, appendix, and some others. So I wanted to show you this. So this is a study we just did with my team at Mayo and presented this year. So this is the incidence or the number of new cases. Let's see if I can. So if you see this here, so this is the number of new cases of pancreatic neuroendocrine tumors in 2000, and then we can see how it has increased. So it's about tripled. And then if we look at the other part of the graph, this one here, it really shows you, and I'm happy to leave these slides with you so you can take a look at them. So what it really shows is that we're picking up a lot more of smaller tumors. And I think there are a couple of reasons for that. So back 20 years ago, we picked up most of the new patients had advanced metastatic disease. Now we're picking up very small pancreatic tumors. I think one of the reasons is that we're just doing so many scans. If you have a little bellyache and you happen to be close to an ER, odds are you're going to get a CT. And so we do a lot of CTs because it's just such a fantastic diagnostic tool. So we're doing a lot of CTs, and we're picking up a lot of what we call incidental neuroendocrine tumors. So I think some of this increase we've seen is really not because they are more common. It's just because we are looking harder for them now, or we have better imaging. So, and then moving on to the next part of my talk, why do we need better treatment options? Why do we even need people like me? Why do we need medical oncologists, or as I sometimes call myself, a chemotherapist? And after the last few talks, well, after listening to other speakers here, one would think that you could just cut it out and be done. And but as Eric and others have shown us, that's not always the case. So some and many patients present with extensive disease where surgery is not feasible. And it can be not feasible because of the number of the tumors there, or because the patient doesn't want surgery, or the patient can't have surgery because of other issues, cardiac issues, and other things. So NETs, as you know, produce a lot of metastases. This is just one case I saw not too long ago. So this is a patient with a lot of neuroendocrine tumor liver metastases. And these will be very, very hard to remove surgically. So this is a gallium-68 scan. This is just from last week from my clinic. So we started doing gallium-68 imaging probably 6 months ago. So this man walks in there, 52-year-old man with a neuroendocrine tumor of unknown primary with a few lesions known on a CT. Relatively asymptomatic, comes sort of for a multidisciplinary evaluation, and we do this PET CT. So these are just sort of the raw images. So there's really a lot of tumors everywhere. And if you look at these are what we call the fused CT PET images. So we can see in the liver, in the bones. And so we know that surgery is not going to help, not at least in the sense of getting rid of the tumor. We may have to do surgery to get rid of some symptoms. Let's say if there's a dominant mass that's causing a lot of pressure and things like that. So this person had no idea he had this extensive disease, just came in with a regular CT scan from an outside hospital, which just didn't show any of this. So then we can have bone metastases, and bone metastases you can't really cut out, and you can't, for most part, ablate, although we do a little bit of cryoablation for them. So they can be picked up on an arterial scan, and think about the scan I just showed you before, that's a gallium-68. So there's really no role for, there's no future for arterial scans. If you have a gallium-68, you should not be using an arterial scan. And I think arterial scans have served us well, and I think they will be riding into the sunset, never to be seen again. And but they really did truly serve us well. So this is a regular bone scan, what's really used for prostate cancer. We generally don't use that much for neuroendocrine tumors, but it can show the tumors. And this is just an MRI, which we sometimes do if we need to plan like spine surgery. Someone has a tumor in the spine and the spine is unstable, and we have to work on that with our surgeons. So we have to do all of these scans. So back to the question, why do we need drug therapy? Why do you need a chemotherapist? And the reason for it is, and this is a busy table, but I'm going to just point out a few things. So this column just shows the percentage of patients with metastases at diagnosis. And this is something I pulled from a lot of different studies from a lot of different countries, but the one I wanted to highlight here is a Canadian study, really well done, that showed that about 20% of patients who had metastases at diagnosis, and about 40% of them would eventually have metastases. And it varies a little bit from country to country, but by and large, metastatic disease in neuroendocrine tumors is very common. So the other thing I wanted to show you is this, and this is the 5-year overall survival. And do not be alarmed by these numbers, because they may not really apply to you as a person, but this is what we're seeing in large studies. We're seeing the 5-year survival of 50% in France. So the Canadian study I just pointed out was 10-year survival of 47%. And this is for all comers with neuroendocrine tumor, not just with metastatic disease. So you can see the same numbers. You can see these numbers. So we need to do better. So they might be just different patients, different registries. Theirs may have lower number of patients with metastatic disease. So you have to take all of these things with a little bit of a grain of salt. So does everyone need to be treated? This is probably one of my most important slides. No, that's a resounding no. So we don't have to treat every patient. So patients with no symptoms, with low tumor burden, and can sometimes be observed. And this actually is reflected in our current national guidelines. So you can actually observe people, but you need to follow them really carefully. What we don't want to do is to say, no, you don't need to be treated, and then have the patient come back in really bad shape 2 or 3 years later. And so you have to watch them very carefully. So, this actually is I just wanted to show you this scan here. So it's a CT scan. This is a 75-year-old man I saw with some other health issues, came in for a kidney stone, and we found those tumors in the liver. And they are small, and they can be surgically removed, but he had absolutely no interest in that. And so we just said, okay, let's just watch you. And so we did. And he keeps coming to my clinic. And some of them have grown by like a millimeter or two, but we're 3 years out, never seen an injection of octreotide or lanreotide, never had surgery, has never met with a surgeon because he doesn't want to. He could have surgery, but he just doesn't want to. Well, he might. I'll send it to you. And so some other treatment considerations. So why do we treat patients with neuroendocrine tumors? So when I meet someone, when I have a lot of trainees in my clinic. We have a very, very large neuroendocrine clinic. And I tell my trainees and I tell my patients there are really two reasons to treat you. So one is to relieve your symptoms you may have, and the other one is to prolong the survival, essentially make you live longer. So if you have symptoms, well, most commonly it would be carcinoid syndrome, but it could also be symptoms from functional pancreatic neuroendocrine tumors, those nasty insulinomas that cause either low blood sugars or stomach ulcers, or there can be big, bulky liver tumors that just cause a lot of pain. And then we have to think about the survival. We can make you live longer. There's no question we can make you live longer. But be careful with the treatment. It's easy to harm a person with therapy, and the harm can be both as a side effect of therapy, and it can also be what we call now financial toxicity. These are really expensive treatments, and if you don't really need them at that point, you don't have to treat everyone. So what we have seen, for example, just to give you an idea how harmful this can be. So I've had 2 patients in the last year who had 3 or 4 PRRTs. And then they had 3 or 4 radioembolizations of the liver, Theraspheres or Surspheres. And 2 of them died from what's called radiation-induced necrosis. So we completely cooked the liver with all this radiation. And they died not from the carcinoid disease, which was well controlled at the time of their death, but they died because the liver couldn't take any more radiation. So we have to be really careful. It's very easy to hurt people. So don't forget that each patient is unique, a unique individual, and all of these neuroendocrine tumors are different. So one size does not fit all. So we've touched on some of these before. So things to consider before you start therapy. Well, are there symptoms? Is this growing fast? If it's growing fast, we probably need to move fairly quickly. Where did it start? The treatments will depend on where it started. What is the stage? Can we get it all out? And then how sort of quickly is it moving? And there are higher grade, like poorly differentiated tumors that need to be treated quickly. And there are some others, even poorly differentiated tumors or high grade tumors that you don't need to treat so aggressively. So this is a really busy slide. So this is just, and I'm just going to walk you quickly through this. So this is another thing I show my trainees a lot. So you get diagnosed with a neuroendocrine tumor, and then you sort of move down this flow chart here. So is it localized? Can Eric get it out? You go to surgery. Is it metastatic? Well, is it then well differentiated or is it poorly differentiated? Because then you have to make a decision. Is it going to be chemotherapy or is it going to be something else? And then are there symptoms? And again, we've talked about this before. And if there are no symptoms, you can observe or you can treat. And this is a dialogue you have to have with your patients. And it's, I'm not necessarily advocating for no treatment, but I need to talk to the patients about the side effects they may have. And some choose to just be observed. And then we have to look at where it started. Is it pancreatic or is it not pancreatic? Because all these things matter. So let's talk about treatment of symptoms. So you all know that somatostatin analogs are really effective. So we've all seen that multiple times. Someone comes in with a neuroendocrine tumor of the small bowel with lots of liver metastases, and they are having 10 to 20 bowel movements a day. You put them on octreotide or lanreotide, and the next visit they come, and the bowel movements are 5 a day. So still a lot of bowel movements, but a huge improvement. So incredibly helpful for treating symptoms, but be a little careful. Here's a thing I see every now and again. So probably once or twice a month, I get a referral with someone with refractory carcinoid syndrome. Someone got started on injections with carcinoid syndromes. The flushing got away, but the diarrhea got worse, or it didn't go away. And then I asked them about the diarrhea. It's the same you had before. And a lot of times they say, no, it's a little different. It smells worse, and it looks different. It's like pale in color. And then you've actually traded out one diarrhea for another. So you've now they have what's called pancreatic insufficiency. The pancreas is not making the enzymes you need to digest fat, and you put them on creon, and the problem goes away. And some of these patients actually have had their the terminal portion or the end portion of the small bowel resected, and now they can't absorb what's called bile salts. And they have a different type of diarrhea. So you need to go into all of the gory details about how the stools look. And you can sometimes really narrow it down, and that's what Derek said. If you meet with a neuroendocrine tumor specialist, they can quickly figure out what's going on. A lot of times, you can fairly quickly figure out what's going on. Is it the cancer that's causing the problem, or is it the treatment? So then we have drugs. We're going to talk about telotristat. We're going to talk about some others here down a little bit further into the talk. And so I think we're still doing okay on time. And so there is a new drug approved. So telotristat or Zermello got approved, I think, at the end of February, early March. So this is a drug that targets the serotonin production. So why do we make all of this serotonin? Well, if you eat food, some certain foods have a lot of amino acid called tryptophan. And if you have a carcinoid tumor, the carcinoid tumor turns this tryptophan into a compound called 5-HTP, which then turns into serotonin. And you can measure it in the blood, or you can measure it as 5-HIAA in the blood or in the urine. But this chemical causes diarrhea. So what if we could just stop the tumors from producing all the serotonin? Well, we could help with the diarrhea. And there is a drug for that. It's a drug that actually blocks this conversion of this tryptophan you just ate, and now it's no longer turned into serotonin. So that's how telotristat works. It's actually a brilliantly designed drug. And how effective is it? Well, it is effective. I wish it was more effective, but it's definitely effective. So there was a study, also published just in the last few months, in one of our main oncology journals, where patients were given telotristat or placebo, telotristat in 2 different doses. And the telotristat, on average, reduced the number of bowel movements by about 2 per day, versus about just under 1 for placebo. So this is not a huge difference. But if you look at the patients, there are some who won't benefit at all, and there are others who will. So I think this is one of those drugs you have to start, see if it works. If it doesn't, then you may have to move to some other treatments, and that could be a number of things, including embolization or other drugs. And another thing that we're actually really interested in with telotristat, and this is unproven, is can we use telotristat to slow down or even prevent carcinoid heart disease? And that's really a topic for a different talk, but that's something that we're all excited about. So new option out there for diarrhea, so be aware of that. And what about the systemic therapy to keep or to shrink the drugs, or at least keep them from growing? What I tell my patients when they walk into my office, if they see me, the drug therapy is not likely to shrink their tumors unless you have a pancreatic neuroendocrine tumor, where we have a very effective treatment. So all of the stuff we have for carcinoid tumors, probably most of it shrinks the tumors in less than 10% of patients, and I tell them that is okay. So we just know that we're not going to shrink these tumors, but what we care about at the end of the day is you living as long as possible with as little symptoms as possible. And I have seen patients. I actually have 2 patients now. I inherited. One of them is from my old mentor in Iowa, Dr. Tom Odorizio, who some of you may know. And still, actually, by the way, still practicing at 73. And so he had a patient of his who had been on with metastatic carcinoid tumor with carcinoid syndrome, and been on injections for 16 years. And they looked at the scans, and it hasn't really changed. And these were all biopsy proven. So anyway, moving on. So sometimes not shrinking the tumors, but keeping them from growing is okay. So we have, to keep the tumors from growing, we have the somatostatin analogs. So these are octreotide and lanreotide, and pasireotide is out there, but hasn't really made its way in to clinical practice, at least not for this indication. So we rarely see the tumors shrink, but we see the symptoms improve, and we see the markers go down. Some of you, so I'm not going to go into the marker discussion. So some people are markers people, others are less of markers people. I personally don't do a lot of markers. I do rely much more on imaging. Very careful, very sort of, when it comes to ordering markers, I don't order a ton. So plasma 5-HIA, chromogranin, and then in select patients, I may get the marker or 2. I do not use the marker shotgun approach for neuroendocrine tumors because it's never been shown to change the outcome. So that's a topic that's really a topic for a different talk. So interferon alpha, some of you may have seen it. It is not that. It's dying, I think, but there are patients who do respond to it, including one patient I saw who was on interferon alpha for 8 years, and then finally the side effects started to just becoming too much. So it's not that, but there may be 1 or 2 patients a year I give interferon. So PROMIT, this has been talked about. So this was really a study in Germany, 80-some patients, all with metastatic neuroendocrine tumor. Half of them got octreotide or sandostatin, half of them got placebo. And those who got apologies for that, wrong button. So it's so half of them, like I said, were treated. Those who were treated with the octreotide went for 14 months without growing tumors. You can see that those who were treated with placebo went for 6 months. So definitely a difference. So this is a useful drug. The Clarinet study, we saw these slides as well. But here's only wanted to point out one thing on this slide. So the placebo patients, so these were all slow-growing neuroendocrine tumors, the placebo patients, they went for 18 months without any therapy. That's the average number. Some of them who were enrolled on the study have not yet progressed. So this is, I think, a very strong argument for waiting sometimes and not treating people who have no symptoms or minimal symptoms and slow-growing tumors. On this study, and progression is more than 20% growth of the tumor. So as you can see, a lot of people can go for a long time with no therapy. The question is, how can we find these people? Moving on, so RADIANT-2 was a little bit of a bust here. So it's a study that looked at everolimus or Afinitor in patients with neuroendocrine tumors who had carcinoid syndrome. It really wasn't a positive study, but the drug has some activity there. And the RADIANT-4 was just published last year. So this was in patients without carcinoid syndrome, so not with flushing and diarrhea. And if you look at the numbers here, so these were patients who had fairly aggressive tumors. So those who were on Afinitor, they went 11 months on average versus about 4 months for those on placebo. So it's an effective drug. I wish it was more effective, but it's definitely an effective drug. Moving on, chemotherapy for small bowel cancer, for small bowel or carcinoid tumors, small bowel neuroendocrine tumors does not work well. Does not work well, and is generally not used. There are exceptions to that. I have used CAPTEM, I have used FOLFOX, generally disappointing. And we'll see what, it's very different for pancreatic neuroendocrine tumors. Yeah, let's talk about pancreatic neuroendocrine tumors then. So systemic therapy for pancreatic neuroendocrine tumors is very different. These are different diseases. This is not the small bowel carcinoid tumor. These are very different. They look exactly or very, very similar under the microscope, behave very, very differently. These are more aggressive, but they also respond much better to therapy. And we've looked at this and we've compared the survival in patients with pancreatic neuroendocrine tumors to those with small bowel neuroendocrine tumors. We've done that and others have done that. And there's definitely a difference in survival. So, but they are, as I said, more sensitive. And here is the thing, and this is something, these are data that we have and we haven't published yet because we're sort of running all the numbers again. We actually looked at the survival of patients with the pancreatic neuroendocrine tumors seen at high volume medical centers versus low volume medical centers. So we're really trying to tease out the big specialized centers, not necessarily academic centers, but just where there is expertise in neuroendocrine tumors. There's actually a substantial survival difference. Some of it may be that the healthier younger people will travel to the specialty centers, and they're going to do better anyway. So that's called selection bias. And but some of it may be, and we like to think it's because we're better. It's not necessarily that we're better. It's just that we have multidisciplinary tumor boards. We discuss with surgeons, with interventional radiologists, gastroenterology, and then we have access to clinical trials, and we just have a lot more experience. So, for example, I see probably 6 to 8 new, or probably 4 to 5 new neuroendocrine tumor patients a week. And so someone out in a smaller oncology practice may see 1 or 2 a year. So it's just, if you see a lot of it, you get better. So octreotide and lanreotide are reasonable initial treatments for pancreatic neuroendocrine tumors, so I use it a lot, especially if they light up on scans like gallium-68. And chemotherapy is actually very, very effective here. So it's probably the most effective treatment if you have like really bulky, painful tumors. CAPTEM chemotherapy is amazingly effective. And, but it doesn't last forever, so probably holds the tumor back on average for about 18 to 24 months. Targeted therapy, here it works very well. Sutent, Afinitor, both work well, and there are some other really interesting treatments out there that might enter the clinical practice sometime soon. So this is everolimus or Afinitor study that compared those two drugs, and those who took placebo, they went on average about 4.6 months without tumor progression. The others on Afinitor went for 11 months. So really effective, really well tolerated. Same thing with Sutent. I'm not going to dwell on this slide because the results were essentially the same. So these are effective drugs, and they don't the effect doesn't last forever, though. Chemotherapy, we talked about CAPTEM. Some of you may have had CAPTEM. Like I said, it works great for pancreatic neuron tumors, actually pretty well for pulmonary or lung neuron tumors, not so well for small bowel neuron tumors. So very, very well tolerated. I'd say this is one of the best tolerated chemotherapy that you can get. So in terms of like old-fashioned chemotherapy. There are some other treatments out there, streptozotocin, doxorubicin, 5-FU, and some of you may have some experience with those. They are not gone, but there are patients who respond to them, but they're generally not used much. So this is a patient I saw when I practiced at Mayo in Arizona a few years ago, came in really, really sick, and he was miserable in pain and had the huge liver and had a pancreatic neuron tumor and completely uncontrolled diabetes that had just appeared in like a year or two, and for reasons really unclear to me, he just was putting off getting in for evaluation. So we started him on CAPTEM, and this is after 6 months of therapy. So it's really, I tried to get the same cut through the liver. The liver was much, much, much smaller, the diabetes was gone, and all of the pain was gone. And he was on this for, I think, a little bit over 2 years when it stopped working and we had to move on to a different treatment. So very effective. PRRT, so what everyone has been waiting for, huh? And we still, and the waiting continues. And so when I graduated from oncology, so I finished my training in 2007, and joined the University of Iowa, and met with Odo Riggio, who said, by the end of the year, Thor, we're going to have PRT. So those who know Odo know he's always the optimist. and here we are 10 years later, and we don't have PRT. But I think we're closer than ever, and we'll talk some more about that. So this is how PRT works. So this is a neuroendocrine tumor cell. So I'm very proud of this. I drew this myself. And so this is about as artistic as I can get. So it has these receptors. So these are like little proteins that sit on the surface of the tumor cell. And we can actually use them for a number of things. And we can put something on it that lights up so we can take a picture. And that would be an octreoscan or a gallium-68 dotatate. A dotatate is really just a chemical that recognizes these receptors. We can treat with octreotide or lanreotide. And if we do that, the drug will bind these receptors and sends this signal into the cell to tell it to calm down. And we can treat it with radioactive chemicals. So what if we had something that binds to this receptor and also has a very potent, like a radiation chemical on it? Then we could really selectively radiate just that cell. So it's just like a bomb delivered to your doorstep. And so this is how it works. So this is a little complicated. So show you here. So this is the radioactive chemical. This is what's the peptide that recognizes the receptors, and then we have these links that bind it all together. And you can see that over there. So what happens is that we inject this into the vein, and this is unfortunately a fairly small picture here, and you can see that here are all of these radioactive bombs floating around in the system, and they attach to the neuron tumor cells to get sucked into the cells, and that's where they get brought close to the nucleus, and that's how they kill the cells. So very, very, very selective. We expected this to be really toxic because a lot of tissues will have these receptors, but it turns out to be an incredibly effective and incredibly well-tolerated treatment. So I'm going to skip through this. This is just some of the early experience in Europe, but this is really where the meat is. So this is the NETTER-1 trial. So this was a trial done in Europe and in the US where patients with neuroendocrine tumors of the small bowel, carcinoid tumors, were given either Lutathera, which is lutetium-177 peptide receptor radionuclide therapy, that is a mouthful, and or high-dose octreotide, which was a very reasonable sort of control group. We didn't know what to do with those who only got the PRRT. We had to give them something. So they got the high-dose octreotide. And then we followed these people along, and those who got the PRT, their progression-free survival, that is the time that took the tumor to grow, hasn't been reached yet. So those who got the high dose octreotide, they went for about 8 months without the tumor progression, meaning that it took on average about 8.4 months for that group for the tumors to grow more than 20%. That's how we define progression. So it's not completely worthless, but you can see that these curves are so far apart that, like we say in medicine, if you have a clinical trial with 2 curves and you can put your finger between the curves, then it's a good thing. If you can put your fist or your elbow between the curves, that's actually quite spectacular. So this, for me, who reads medical literature all the time, these are one of the most striking survival curves I've seen in the last 10 years. So there's just no question about it. And I am completely unbiased. I was not a part of this trial. So with all of this efficacy, shouldn't it be toxic? And and how effective is it in shrinking the tumors? So it's not like super effective in shrinking the tumors. About 17% or so had a notable shrinkage in the tumor. But then again, I will take prolongation of survival and improvement of symptoms over shrinkage anytime. And then what about the toxicity? So any adverse event. So about 10% so this is these are the lutetium or the Lutathera group. So if you look at these numbers, about 26% of them had an adverse side effects of some sort, and the 9% of them was related to the treatment. A lot of it was nausea, and it's not from the treatment. It's from the amino acid solution we give with the treatment. That's actually changing. So we're going to get a new solution which is not nearly as nauseating as the old one was. Moving on, so this is just some data from our Iowa experience. We had 135 patients. We treated almost entirely in Basel in Switzerland, mostly with yttrium-90, which, by the way, I hope doesn't disappear, because there are some differences in yttrium and lutetium. And I want to, I think that needs to be examined a little bit more. So this was a mixed bag of patients with neuron tumors, some small bowel, some pancreatic, some lung, and some unknown primaries, and some other really rare ones. And what I wanted to show here is that with the small bowel neuron tumors, so patients on average lived for almost 200 months from diagnosis. And their survival from the first PRT, and then by that time they had seen a lot of treatments. Their survival was about 10, almost like 100 months. So we're talking long survival. For the patients with pancreatic neuron tumors, not nearly as good, but still fairly good. So overall survival from the first PRT was about 37 months there. So we need to have better treatments for the pancreatic neuron tumors. But keep in mind, they have Captem, Sutent, Afinitor, some other things that are all quite effective. So what's going to happen with PRT? It's not yet approved. We think it may be this year or next or the following year. And I think actually we're getting really close. So, but then even more importantly, what will the approval look like? Will it only be for small bowel neuron tumors as was tested in NETTER? Will it be for all neuron tumors with somatostatin receptors that light up on scans? We don't know. I hope it's number 2, but no one knows. There's a lot of interest among other pharmaceutical companies now. There will probably be 2 or 3 clinical trials of different PRTs. 2 of them are lutetiums. I'm not sure if the University of Iowa will have an yttrium trial. They actually have it ongoing right now. And so I hope to see a lot more clinical trials testing different tumors, pancreatic tumors, lung neuron tumors, and so on and so forth. So highly aggressive neuron tumors, I'm going to go quickly through this because I think I'm going to spend the last few minutes on the genetics of these tumors. So really chemotherapy for most parts. We can address this in the questions later, so I'm going to skip through this. So what's on the horizon? So we have targeted therapy. Hasn't been the magic bullet in oncology that I thought it would. So our targeted therapy probably started in the late 90s, like the early 2000s, when we got a drug called Gleevec for a certain leukemia. And we completely just hit the ball out of the park with that. And it's amazingly effective therapy. And then we thought, well, we got it. So, and most targeted therapy doesn't even come close to it. But we are making progress. If you look at a lot of different tumor types, patients with metastatic disease are living longer than ever. And that goes for all kinds of different tumors. So we can target all sorts of things. We can target formation of new blood vessels. We can target the machinery in the cells and your own immune system. And I'm going to show you a few examples. So what if we could stop neuron tumors from making blood vessels? So if you have a tumor that's growing, it needs nutrients and it needs blood. So what it does, it sort of taps into your own blood vessels, it makes its own and starts sort of mooching off your own blood system. And so if we could just stop them from doing that. So let's say if we see this here, so these are the blood vessels feeding the tumor. If we could give them a drug that stops it, we could shrink the tumors. Well, this is actually what the interventional radiologists are doing with the embolization. So can we do it with drugs? Yeah, we sort of can. And we have Sutent that does this. Avastin, which hasn't been as exciting as we thought it would be, or bevacizumab, and some other similar agents. So this works for pancreatic tumors. For small bowel neuron tumors, we don't really know yet. Our drugs that stop the formation of blood vessels are just not as effective as I want them to be. So moving on, so this is just one clinical trial that maybe some of you participated in, looking at a drug called pazopanib or Votrient, which is approved for kidney cancer. So patients were randomized to either placebo or pazopanib. If they progressed and were on the placebo, they got on the pazopanib, and if they progressed, they were taken off the trial. So it's a very simple design. This trial is done. We may have some results coming up in a couple of months. So we have a big meeting coming up, and I'm hoping we'll have some early results there. And there are some other drugs. There is a drug called cabozantinib. I want to know who names these drugs. So it's regorafenib, and it just gets worse from here. Trust me. So so all of these drugs actually are showing these really early sort of encouraging signals, but they are all like very small trials. We need to do bigger trials. So I'm not going to explain all of the things here, but this is sort of a part of the machinery that keeps the cancer cells ticking. So we have all of this. It's like a clockwork. So it's all of those little cogs, and they all have to fit together and play together, and so it's really complicated, very intricate system. But what if you block one or two of the cogs? You can make the entire system just grind to a halt. But unfortunately, most of the times the cancer cells figure out a way around it. So this is just a similar, much more simplified schema here, so I'm going to go through that quickly. The last thing I want to talk about is immune therapy and the genetics. So immune therapy is getting a lot of press. I probably have at least 1 or 2 patients a week now who comes in and wants immunotherapy. The short of it is, it isn't proven yet, but what the immunotherapy is doing, the most effective drugs, is that it's really stimulating, revving up your immune system. If the immune system was good at recognizing and treating cancer, there would be no oncologists. The immune therapy truly sucks at dealing with cancer, and that's why people get cancer. And the reason for it is that the cancer cells, they can fly below the radar of the immune system. The immune system is out there and is looking for cancer, doesn't see the cancer cells, because they are just smart. They're just flying below the radar. And so what we're doing with the immune therapy is to try to rev up the immune system, so the immune system has these natural brakes on it. Because if it didn't, it would kill you. So that's what happens with severe autoimmune diseases like certain arthritis and inflammatory bowel disease. It's your own immune system is attacking your own cells. So what we are trying to do is to sort of lift the brakes of the immune system, make it a little bit more aggressive, sort of train it how to recognize cancer cells. And this has worked beautifully in melanoma, and now we're getting, every week I'm getting these emails from the National Cancer Institute. This new immune drug was approved, and actually there was an immune drug approved for a neuroendocrine tumor. I'm not sure if anyone here is familiar with Merkel cell carcinoma. It's a nasty, high-grade neuroendocrine tumor caused by viruses and sunlight. And so there was a new drug called avelumab that was just approved for it 3 or 4 weeks ago. First, so I look at that as a little bit of a victory for us neuroendocrine oncologists. So there might be some hope there. So a lot of interest, no large studies. We did have a study at Mayo. It's closed. We haven't seen the results yet. We're opening up a study in 2 weeks with a new immunotherapy drug from Novartis. We have another 2 or 3 concepts cooking. All of the drug companies are now looking at immunotherapy. There will be clinical trials. We can sometimes get this, what we call off-label, compassionate use, but they really encourage everyone to seek out clinical trials with immunotherapy for neuroendocrine tumors. That's the only way we will know if this works. Personalized therapy, it's my last 2 slides, 2 or 3 or 10. And so, no, we're almost done. So it's so a lot of patients come in and say, well, can't you do like some genetic testing on my tumor and find the target? Yes, we can. We do that all the time. But with neuroendocrine tumors, we almost never find a suitable target. So there are all sorts of ways of scanning the entire genome, and we may find mutations, but we may not have a drug for that particular mutation. So we have all sorts of ways of doing it. And but there are problems with personalized therapy. So we find mutations which we don't understand what are doing there. So there's a mutation, I'm just scratching my head and what does that really mean? I've never seen that before. And then we have mutations of unknown significance. We have a lot of times where there are no mutations, and that's actually particularly common in neuroendocrine tumors. And if we find a mutation, so is there a drug? And maybe it's a drug that we can use for some other kind of tumor. For example, we have with biliary cancer, we're now using a leukemia drug that seems to work well for some patients with a very, very particular mutation. So, and if there is a mutation and if there is a drug, can we even get the drug? And if we can get the drug, who's going to pay for it? Is insurance going to do it? Probably not. So that's another way to, another reason to get people on clinical trials. We actually are going to have a couple of these trials with very specific targeted drugs for neuroendocrine tumor patients. So personalized therapy, it's not the reality yet. We're making some progress. We're not quite there yet, but it's and the problem is because there are not that many mutations. And what I wanted to point out to you is a couple of years ago, and I've shown this for a few years now, there was and I'll give you the link, there was a really nice, very, very well written piece in the New York Times on these targeted therapies and the trials. So personalized therapy is in the future. We're a part of it in the future, but we're not quite there yet. So I think what I'm going to do is just to skip to the sequencing of therapy. So that's changing a little bit. So and I'm going to go to my last 2 slides here. So this is the way we sequence therapy now for small bowel neuroendocrine tumors. So we started with somatostatin analogs. We move on to everolimus. So obviously these are generalizations. There are all sorts of twists to this and the embolizations and surgeries and whatnot. So then we do something else, clinical trials, chemotherapy, who knows, and then PRT for those who can get PRT, can go to Europe or to Texas and get it done. So the future sequence is almost certainly going to look like this. We start with somatostatin analog therapy. Once they don't work, we're going to go to PRT. I think there's no question about that. Then everolimus, and then this other part is going to be further out, and that would be clinical trials. And then, as I said, anywhere along this line, we'll consider surgery, embolization therapy, and those kinds of things. So what about pancreatic neuroendocrine tumors? If there are no or minimal symptoms, we start with somatostatin analogs, Afinitor, or Sutent. If that doesn't work, we switch to whatever we were not getting before. So I have no particular preference there, at least if there are no symptoms. And then you can use those 3 drugs, you use them, and the sequence probably doesn't matter all that much. And then we move to CAPTEM, and then we move to something else, and then possibly the PRT. If you're having hormonal symptoms, then we should definitely start with somatostatin analogs. Then move to CAPTEM possibly, and then everolimus or sunitinib, and then so on and so forth. If there are symptoms from tumor bulk, painful big liver, things like that, then we start with CAPTEM or other chemotherapy. There's a chemotherapy called Folfox that sometimes works well, everolimus, Sutent, those kinds of things, and then PRT. Hopefully, eventually, we can move the PRT from the back end much more up front, but that all remains to be seen. So, you're all awake still, mostly. So thank you for, again, thanks for the invitation. So if anyone wants to come for an evaluation at the Mayo Clinic, we're always happy to see new consults. Thank you.